Thanks for the invitation. It's a pleasure to be here. And as soon as I got the call a few weeks ago, I said I'm happy like present and figure out how to collaborate and work together on these. So keep that in mind as I'm going through. I'm going to tell you a bit of our history and kind of the journey that we took, but there's a lot of things that are work in progress and not solved by any means. So I don't have any relevant disclosure. Are the slides going through?
You're still on the, there, now you're on disclosure, yeah.
Perfect. So I don't have any disclosure. I always like to check because I don't trust technology in spite of all the work. So I want to acknowledge a huge team and leadership that are behind these things. So there's a lot of collaboration, a lot of people, a lot of nights we've overworked, particularly at the beginning of this journey, and many disciplines involved. And when I was thinking about this talk, this phrase resonated with me. There's nothing quite new is perfect, and the truth is that virtual care is not quite new, and I would argue also nothing is truly perfect, and perfection is enemy of the good. So that's what got us moving into this, and I want to put a definition off the bat around what virtual care is, and I think it's important to have definitions because there's always a little bit of confusion on this field. So by this, I mean any interaction remotely when there's a distance between the patients and the providers or the healthcare system, and uses any form of communication or information technologies. And the aim is clear, is facilitating and or maximizing quality and effectiveness of care. And I love the importance of definition. I don't know if anyone knows how that part of the shoelace is called, but if you don't have the correct terminology, you will start to say, well, the thingy on the thingy that helps to put the thingy inside. But it's, I don't know if anyone knows or not, but I'm not on a live audience, but that's called an aglet. I don't know even how it's called in Spanish, but I think it makes the point. So I decided to divide this talk a little bit different than my usual spiel in terms of past, present, and future work. So it gives you a flavor of what we have done, what are the current kind of pressing needs, and I'll work around one example and some future directions. So what got me into this to begin with was frustration. I got this feeling going into a clinic, and I felt that fundamentally we were doing the same that some of my mentors, which I admire and love deeply, were doing exactly the same 30 years ago, with maybe a little bit more monitors, maybe more fancy things sprinkled in the clinics, but not truly fundamentally different. And as I was doing some effort in that grant, I also realized that there was a colleague in my same site group in genitourinary oncology doing something very similar. And this is kind of what starts happening in healthcare, that someone has a good idea and creates this spark of light on the darkness and starts working on it. But at the end, it also generates cracks that if you navigate or try to navigate from a patient perspective, or from other providers' perspective, these create gaps where patients or providers or our system can fall through those cracks. So we said, can we do a more conscious and organized, and maybe even a program that can direct to try to put these efforts in a cohesive way? And that's how the first program we created back in December 2019, called Smart Cancer Care, had these fundamental pillars. We said we want to increase capacity and research, and that's kind of the mass of our iceberg. But in the surface, what will emerge, and the more research and the more capacity we have, should have higher exposure to a better patient experience and a better provider experience. So those were our kind of guiding principles, and we said any project that we take should tackle these four elements, not one at the expense of the other. And then the rest is history. There was COVID, the pandemic, and this was early March, and I got one of my favorite, if not my favorite mentor, coming to my office and said, you have to help transition 50% of the clinics to virtual care. So obviously the first reaction was, this is crazy, or it's impossible. But now in hindsight, and that's why I'm putting a little bit of lesson learned, I think COVID rallied us into a common goal. There was this sense of urgency. The goal was explicit, was 50%, was not a lot, or the more, the merrier. It was 50% or more. And we had permission to act and try figure out these problems. So because of the previous project that I'm gonna go into it a little bit later, we had mapped the clinics, but we went back and did a deeper mapping. And what you see there is a service mapping of all the steps that happen on a clinic, and different lanes represent different actors: clinician, nurses, flow coordinators, administrative assistants, patients, and what happens and where are the transitions. And then we envisioned that we needed a system in two critical transitions. One was, can we look the clinics that are coming ahead and do a simple triage system where the clinician can say, this patient needs to be switched to phone or video, and communicate that to someone, and that we can track completion. So it's not a post-it, it's not printing out a list and stuff like that, because people also weren't co-located in the same place. And the other functionality was the communication of orders at the end of the clinic, where medical orders were left sometimes for nurses or patient flow coordinators. Can we centralize that in a digital system where, again, we have tailored orders for each clinic, and these can be tracked and monitored for completion's sake? And we launched that system in about 2 weeks. So it was a massive effort, many people facilitating and supporting, and I could spend the whole hour thanking many individuals that made this possible. But the most important thing is that within a month, we reached that goal of 50% into virtual care. And not only that, the system has remained, and we are now at around 50% overall. This varies per clinic to clinic, and has also translated in a sustained increase in capacity of about 20 to 30% of the overall clinical volumes of ambulatory care. We run patient satisfaction surveys in parallel with this. So I'm going to show you another system that we ramped up during the period. And you can see that most patients are satisfied, over 80% with the remote appointments. They feel that it's the same or even better in the majority of cases to in-person care. They would like more appointments, and mainly because of convenience. So we quantify that elephant in the room, and the out-of-pocket expenses for a patient in terms of travel, opportunity cost, if you put all that together, is around $130. And this is a deep cost to our system, and that was another impetus to keep these going. So how we kept these going, again, I said I was going to start showing some of the things we built, and we put systems in place to analyze in real time dashboards what were the functionalities that being used. And you can see, for example, in the center bottom, triage is less and less used, because now the patients enter this next visit is phone again. So there's no that pressing need to triage upcoming in-person visits. But the digital orders functionality has remained a core functionality of our ambulatory clinics. The other thing that we had to transition was the collection of certain patient-reported outcomes, DART, that collected ESAs, and some other surveys that was done in person with iPads, and that was obviously from an occupational health and infection control felt to be a risky procedure. So that was stopped, and we built a system for electronic collection that will connect with several of our systems, the scheduling system, pull the information of the patient, send the survey 48 hours before completion, and then feedback the results into the electronic medical record and into our system for coordinating virtual clinics. And again, I want to show you how this mentality of our team is like, we want to measure at every point of the time, not just throw a system out there, but we have these funnels, and we know once the patient logs in and start the survey, the completion rate is 95, which is pretty good. But if the login successful to start the survey is 72, so there was some friction there, and that was the point we were start to work and remove that friction from the system. And in the right, you see a heat map that you know where the mouse or the clicks of the patients are going. So you have these analytic layers on all the systems that can inform and say where the patient is losing their attention, where they drop the system, so on and so forth. And the same we did this with the dashboards with patient experience. We can now gather the patient experience in terms of virtual care or other elements on your Voice Matter, which is the provincially mandated survey. And we can filter these by clinic, by location. We haven't done it by provider because it can be a bit more sensitive, but we could in the future once the mindset is there. But that allows you to measure and start figuring out the problem. So again, if a lesson was learned here is these kind of, usually in healthcare, we do very stepwise approaches, but this was a constant discovery and then start designing and testing. Some of the solution and the dashboard you see there is the version 1 year after. The first ones were a bit more clunky, but as you implement and you improve, you continue to learn, and then you make sure that your goals remain aligned. And the last element I want to mention here is because I think this was also a deal breaker for the future and current work that we're doing, was a nurse-led COVID clinic in which there was a lot of friction, tension, and stress related to a patient with cancer, receiving cancer care at any point of their journey and having a positive COVID test. Because we did systematic asymptomatic screening before starting treatment, or because the patients were doing it in the community, and we had an alert system that will tell that a patient had COVID. And then there was a whole emails going back and forth, occupational health, infection, disease, what is going to happen with the management. In the case of radiotherapy, letting know the treatment unit that the treatment is postponed. So we centralize that on a single form that then will triage the information to all the stakeholders. So you get the information, you see it in one form, you complete everything, and that sends to occupational health, the managers, and so on. And also we'll pass the baton to a nurse-led clinic, which will have standardized templates and algorithms to monitor the symptoms, schedule the clearance swabs, and then get the patients back into the, let's say, planned treatment, cancer treatment plan. So I think that gives you a flavor of all the work. I'll be happy. I'll leave obviously time for questions at the end. I'm monitoring my time. I want to leave time for interaction, but I wanted to talk to you about a current challenge, which is the use of video conference, because I think it exemplifies both the way we've been working, the current state, and how things can get fixed over time. Because there is this feeling in some providers that perceive a video visit over phone, and the truth is that it's not exquisitely well quantified or defined. There is some data that some patients will prefer video, and also apparently some regulatory agencies in the province feel more comfortable with video because there's more room for checks and balances than with phone, although there are technologies on the phone that will allow you to have the exact same checks and balances. So the problem we faced was that OTN was overwhelmed, understandably. Like, no one builds a system to be prepared for a pandemic like this one. And maybe we should in the future. But the thing is also the workflow, if you see again, had redundancies, because once the patient is booked, you had to enter a separate system in OTN in this case to do the booking, have the actual appointment, and also when you're having the encounter, now you have a separate system running on it. And we had, as an institution, MS Team was the preferred and let's say approved vendor for video conferencing, and was part of the Office 365 suite, and was approved from privacy and security perspective. So we had to build that into a platform that could be integrated again with the clinics. And these are some of the steps, but you think it's very easy with an off-the-shelf technology, but bringing it into the fold of the workflow is actually pretty complex. You have to create specific codes on the scheduling system, new licenses using the booking system, training session, pilots, scale up, so on and so forth. And you probably are familiar with this when you're trying to ramp up anything that is new. But I just want to show you two of the things that I think are key, or we thought were key to again, remove some of the friction on integration on the system. So one was the booking. So the booking with the integration of the calendars will put that appointment automatically on the calendars if the proper permissions were given to the scheduler. So now you can launch from your Outlook calendar, which is what we use for work. So you don't have to be jumping to find where is the link, where is the visit, so on and so forth. And the other thing is that we integrated that link into our management system, which was one of the functionalities around putting the digital orders. So again, when you see your clinic list and one visit is identified as MS Team, it's just one click away to open the pop-up of MS Teams. Other thing we have been working is saying, okay, let's feed back informations to providers. It's not just saying, oh, we have to do more video. It's like, how much video am I doing? So these reports also automatically at the end of the month will tell you how much video visits are you doing, how that compares with your peers. It doesn't put the name of your peers, but I think physicians, we do like some competitiveness to drive innovation forward. So it tells you among radiation oncology, genitourinary, or melanoma, whatever site you're doing, you know where you're at, you know your trends, so you can work on your improvements. And the other thing is that it allows integration of multiple actors. So you can put participants in here and that we can bypass the lobby and if they have a UHN address so that no one can send to external users, only the organizer. And also it could be dynamic. If you have a trainee or pharmacy and they know that you're running a clinic, you can call them into the room the same as you would do as an in-person visit. So now it's not a technology problem, it's saying, well, how do we make people to work to know that they might be called into a room, which is now not an in-person room, but an MS Team room when an encounter is happening. So I think we had pretty well mapped this problem to start executing, but then at the organizational level, which starts to happen, we don't work in silos. There was an off-the-shelf solution that will solve all these problems. And I'm usually pretty optimistic most of the time. I'm critical, but I like to think it's going to work. But when a vendor comes and they solve every problem and they do it all, my alarms start to go up. So I was one of the naysayers on this one. And there's nothing better for a naysayer to feel that he's right afterwards, because that pilot actually didn't came through and that technology is not being adopted at UHN. But there's a lot of learning lessons that came out of it. And also with the work being done prior, with the work of those pilots with that technology, there was understanding of how these should integrate. And we're in the middle of a migration into a new health record system. So again, another massive earthquake for us as an organization. And this is some of the things how we think it should look. So a patient will get an email where they check in online. The check-in online can happen anytime before their visit, and then they will put some information that will be felt to be critical, like medications or allergies or health issues. And then after that, they will be able to join the video visit, and this link will only activate 15 minutes prior to the visit. So that's another point of tension where people are logging in 5 hours in advance. You enter the room at the scheduled time, but they're mad because they have been waiting 5 hours, but it's not your fault. They just log in way in advance. So these just manages kind of that expectation. And then the other thing on the other side of the provider, it's fully transparent in terms of knowing which patients have completed the check-in. You can see that area there. So they're kind of working towards that. If they're not, you can nudge them or contact them. And also in the video visit, when the patient has logged in, because once the patient launched their Microsoft Teams, there's an interface now with the electronic medical record that will flag that patient is in the brackets waiting room. So again, all about transparency and putting the expectations right, but making these kind of bumps on the workflow smoother for the people who are acting on it. And just a final note on the present work, as we're introducing these things, it starts to become a very critical point to say, well, are we leaving people behind on this? So we conducted a study over several months of people, and this is interesting because there's people there's populations who start to shrink. So there's the overall patients we saw over 3 months in this case. So it's 42,000. What I'm calling here surveyable patients are patients that have email on file. So you can say, well, do they have access to email? So then you left some people out because they don't have access to email. And then you send email surveys and you say, well, some people don't respond. Maybe it's people who are busier or more marginalized. They don't have time to respond to the survey. So as we're using these digital tools, we wanted to start exploring these. And what we found actually was pretty comforting, that in terms of, I would say at scale determinants of health and inequalities, there's no overt difference between those are surveyable and non-surveyable. So those that have email or don't have email. There weren't difference between in-person and virtual visits, and also those that responded and did not responded the surveys. The only difference were on age and gender in one of them. So it seems that these tools actually could be leveraged to start using them as a way to start reducing some inequality gaps, because email and virtual care are becoming super, I would say, intrusive in our society and every corner of our society. So a little bit of words towards the future, and I said I will leave at least 20 minutes. That's my goal for discussion, and we're pretty much on time. So eventually what happens with all these headaches that you can imagine is like you're battling on many fronts, things and dots start to converge and connect, because now you have a repertoire of initiatives and things and tools, and also the mindset of the people starts to shift. So I want to show you 4 examples of these that I think exemplify well kind of what's the direction that we're taking. So first was that these smart cancer care, and there was another initiative I was part of called PM Data Science, converge into one. So we had a change in leadership, and we are fortunate that Keith reaffirmed the importance of digital intelligence as one of the pillars of the cancer center. So we were, let's say, challenged with creating these, I would say, more bold and bigger vision from a cancer digital intelligence perspective. So we created this program. That's the vision and our mission, and we have a foundation of data science and analytics, and then we're working essentially in 3 domains: BI, CI, and DI. The idea there is that while everyone is very excited with AI, we're going to keep going on the alphabet letters, but it's business intelligence in terms of operation intelligence, care innovation, and integration of discovery and research work. So I'm going to talk about one of them so you get a better flavor of these. And there's a website, and I'm happy again to discuss this. So the work that we did with this platform called PATH, Princess Margaret at Home, and the COVID clinic opened our eyes for the need for triage and monitoring. So we knew that this was a need, an unsolved question, and we now had, I would say, good positioning and good tools to start tackling. So this care innovation, as I said, one of the domains, we're trying to streamline the patient experience, enable access anytime and anywhere, and augment capacity to deliver patient care. So we said, can we put digital innovation to work and help us on these tasks? So why is that motivation? Because we know that the patient encounters only represent a very, very tiny percentage of the patient journey. And that we said, how about we start shifting that focus to the 99% of the time where the patients are not co-located or at the same time interacting with a provider. And you might be surprised a little bit why monitoring is with triage, but we have a problem that patients call our triage lines with many sorts of issues. Can be symptoms, can be asking for the parking rate, can be asking for rescheduling an MRI that was booked at 4 a.m. in the morning. So obviously there is an overlap between triage and monitoring responses. And we also know that there over time in the patient journey, there's different intensity of needs, where during treatment, monitoring needs or response to symptom needs are more intense, but then the triage needs remain overall the entire journey of the patient. So we think these are 2 functionalities that should go hand in hand. And I think that is in part a somehow novel approach. So we have envisioned this integrated service system. And again, the emphasis is on the service you want to provide more than the technology, but it's anchored on these 7 elements that I have listed there. So there is a questionnaire, there's algorithms for alerting, relevant people, some self-management, because some things might be easier and addressed automatically to the patient, like the parking fee should not need a human to report that. The provider dashboard, so they can keep track what's happening with this patient population, documentation tools, care pathways, and again, communication channels that are leveraged to these. It could be phone, video, messaging, depending the task or the challenge at stake. So we have 7 initiatives running now with different technologies, with different milestones, because we're kind of encompassing the entire spectrum. And the idea is start consolidating them afterwards and then optimize and scale up. So we have from just patient-reported outcomes-based to nurse-based proactive calling, nurse-based calling based with some pros and prems feed to their dashboard, biometrics projects, 2 of them, and now a hospital-wide triage system that stemmed from one initiative with our supportive care team. So let me go to a synchronous visit, because I think this takes a little bit more and also refine some of the concepts I mentioned before. So we currently see all the encountering happening at one time. So patient comes in the clinic, patient is on the waiting room, they enter the room, a lot of stuff happen, patient leaves, some administrative things happen, and we're trying to pack a lot on these. And the question is, can we use technology instead of replicate that model and put the tension there, rethink about it and say, maybe we can deconvolute it away. How about if the patient goes into a waiting room and has the first appointment, let's say with the nurse, which is not necessarily what happens, and then they leave, and then there are some next steps, and then pass the baton to the next one, which could be the physician, and then the allied health, and so on. So now you don't have the pressure to coordinate all those resources on real time. And this may work for some sites, but may not work for others. And these, I'll look back to where I started saying, can we even be more blunt and simplify things? Is actually needed to be 2 people at the same time interacting, or can we just base the tasks that they do so they do it asynchronously on time? So this is the concept of an asynchronous visit, where there are tasks. This is not the Wild West messaging that is back and forth with whatever. They're very structured, they're digitally mediated, it's all data driven, and it starts tailoring demands with the resources that you have and aligning priorities. So the definition is down there. We came up with this definition. So it's a set of disease-specific, predetermined, and auditable tasks that both patients and providers complete within a scheduled timeframe. So the whole package is the visit. It's almost the same that will happen in the visit, but just back and forth task. And I will give you the tangible example. And that's why I said it's important to have the definitions back. So that's why I have the aglet at the top again. So how would this happen? Is saying to the patient, you see him on the clinic and said, look, I'm going to onboard you on a platform. This is not a black box. It's not something you go and download on the Apple Store. This is a prescribed digital application in the point of care, because it has to build that trust at the beginning. So the patient gets registered, and then there's some registration information that helps for the context. What will happen from the patient side? So they will get a reminder in X amount of time and said, it's time for your follow-up. And then they have tasks, complete the blood work and record the symptoms. And the symptoms and the blood work obviously tailored to their disease. And once they complete that, they again have explicit expectations in terms of saying, your doctor is reviewing these, you should get a response by November 15 or whatever the thing. And also when the results are there, we're connected to Oli so they can see their own results. And the last one is what happens when the provider has seen and addressed the things and said, there's no concerns. I want to see you in 6 months again through these. It's all good. The patient confirms. If not, if has some more questions not addressed, they can request a phone or a video or an in-person synchronous visit. So you can always escalate back and leave that as a fallback kind of a scenario. So this is how the provider side looks. So you have all the information there in context. So you have the registration information, the results, in this case, PSA and testosterone, and a very simple way to document what your action plan will be. Like, I don't need a video call, I have no concerns. You can put additional comments. It's like, dear Greg, I hope the wedding of your daughter was phenomenal. And then you can say the follow-up plan is in 3, 6 months, 1 year. And once you click send, again, automation, sends that to the patient on a patient-friendly note, sends a synoptic documentation in the electronic medical record, and in the system stamps the next visit. So everything is aligned to happen again, including your outside lab requisition that has been digitized. And obviously you have a tracking system, because if the patient hasn't complete things or they called, you want to have a dashboard to monitor and say, we spoke to them, he's delayed, he knows about that and everything. So think about it in a second. How much of the things in oncology, and that would be interesting of people's thoughts, we could do on these? How many visits that are very routine and very straightforward could be carried on these? Prostate was the example, is because I started working on there, but imagine patients undergoing certain oral agents that are on them doing well after many years. You could save them visit and that need to refill a prescription, so on and so forth. Other disease sites like breast, thyroid cancer. So I think this could be transformative, and it's a nice way to move forward our field. And last but not least, with all you're delivering results and building trust with the team, and people are engaged and excited about these, you can start thinking on solution-oriented work and where the roadmap for the organization starts to go. Because there's a lot of guidelines, and we love guidelines. They tell you the why, sometimes the what, but not really the how. So this is a big kudos to our leadership, and Monica has been extraordinary leading many of the COVID efforts and virtual care and the clinical practice of our ambulatory clinic, working side by side with Leslie Moody, our director of clinical operations, and they're truly extraordinary and super well supported by Keith office and NASEC working there, leading this work. So this was an internal scope, and it's very concise, but there's a lot of work and pearls of wisdom. We have shared these with Drs. Mackay and Simron, and I'm happy to discuss and figure out how we can enhance these. But I'm just going to walk you through some of the elements, because I know those are kind of what we feel are the tension points. First, the surveys have expanded. We have now over 4,000 patient surveys around virtual care, and it might sound surprising, but most patients actually do not make big difference between phone and video in terms of when they feel is appropriate most of the time. And most patients will be okay doing most of the time remote care, perhaps not when they're getting bad news, which is understandable, and in their first visit with their doctor. Aside from that, they're pretty keen, and I would say they would favor outpatient care, virtual care. So that helped us define what we think are appropriate things, because once you start with the definitions, you can put objectives, implement, manage, measure, and improve. And what are the scenarios where a new patient might feel appropriate for virtual care? Which type of patients in the middle are adequate for treatment? And which other patients on follow-up remission are okay for virtual visits? And again, there's always the support required in terms of clerical for booking and orders. So another thing that we've learned is the scheduling logistics, which is a major pain point. The current state is that people have all over the place hybrid clinics, in-person, phone, in-person, phone, video, and it's all intermingled. Or they have dedicated virtual visits, but they do it at night because it's easier and everything, but then the clerical support is not there, or just impromptu. And the other thing we have learned is that when it's virtual, they're more likely to be bumped down the list of the clinic, because you have someone waiting in the room. It's kind of there putting the pressure. If someone on the phone, I say, well, I'll call him towards the end of the clinic, but that person is sitting next to the phone, waiting the call that has been scheduled for 3:15. And the other thing is the patient preference, that there has to be a way to document these and put them into the fabric of the decision making. So we're starting to work towards that, specific time blocks where you can split in person and virtual, not necessarily different day and time, which might be perfectly fine, but at least back to back. So you can not transfer or downstream the complexities of one into the other. Put realistic time slots. It might be a phone call, but it's not going to take you 1 minute unless you do prostate cancer like me. But if it's going to take you 5, 10, 15 minutes, then put 5, 10, 15 minutes. I know it sounds hard and sometimes it's impossible because we're at capacity. But if we don't do that, you can't quantify, you can't measure, you can't really improve. The other thing is the learner integration. There's truly a need for processes to support this. I think the technology is there, but it's there's need to be some work ahead of time and defining and say what is the appropriate mix of virtual and clinic that will allow the virtual visits to contribute to that learning experience. Obviously, the platform should support, and we as providers need to learn. This is a new way of practicing. We have been practicing the same way, as I said, for 30 years, and that was my frustration. So now I have to kind of say, well, was the frustration and now is the challenge, but it's a different environment and we need to learn from it. And I think the UFT put a very nice document, 2 pages, that gives some good ideas around these, and the reference is there. And this tags to the point that I was just making around provider education. So there's obviously room for improvement. There's need for change management because we have worked always the same way, and there's explicit new competences that we need to consider. And what I like the most about the way I think we're working is that innovation and monitoring are integral parts of this. It's not just saying, okay, these are the recommendations. It's also, how are we going to monitor this? How are we going to make sure that we're in the right direction, that we're closing that gap, and that also we're innovating this step, because we might be unconsciously or consciously just not maximizing the opportunities. And there's always this tension of balance between operations and research and development, and what's the right balance is something pretty hard to find, but I think putting that as an explicit goal helps move the things in the right direction. And this brings me to my last lesson learned, that I think in medicine, we're very good on doing a very traditional way of waterfall doing things and innovation. It's kind of, you define specification, you put an RFP, you procure a solution, you implement, and then most systems or support system just walk away. And that a priori A leads to B, I think doesn't exist. And it's just working through the process and say, well, I want this placement in the case of this minimal viable product or minimal viable service that you want to build. If you start doing that and say, well, let's do a skateboard and then a scooter and then a bike and then a motorcycle and then a car, you may realize that the car that you end up at the end is a convertible, because you learn through the process that you enjoy the breeze of the air on your face, and not the car that you envisioned initially would be the car that would fulfill your needs. So there's a way more focus on the individuals, what is the working solution and response to change, than just following a plan that it's defined a priori without true understanding of the problem. So in summary, I think in my view, virtual care is here to stay, and we should take it as a fact of life. And there's obviously opportunities to improve, and we need to start thinking, moving beyond just digitizing the way we're doing stuff. And good levers for success in our case have been this multidisciplinary approach, having explicit goals, support from leadership, service focus on both improving patients and providers' experience, this agile approach that I mentioned, and an obsession towards measuring and data-driven approaches to guide decision-making and improvement. There's obviously lots to be done. In general, the billing codes are some degree of uncertainty. There are regulatory and privacy legislations that need to be modernized, but also in particular us as oncologists, I think we're being lumped into virtual care, but the truth is virtual care for specialized care, let alone oncology care, has different needs, different expectations, and different issues that will have primary care. And the focus has been in primary care because of volume and because of many other reasons, but I think we need to work harder as a group. So I think that's what excites me most about talking to this group, and the honor of the invitation, because I think this is a great opportunity for both groups and others to work together and make a tremendous difference, not only here, but globally, because no one has solved really this puzzle, and the timing just seems awfully right and due to try to make the way we work in the clinics better. And I'll close with a thought, and I'll give again credit to Mary G, who's one of the best, as I said, mentors one can dream for. But this wasn't a talk that we had here about global health, but I think applies to everything. And it's saying, well, if you're doing nothing, just start by doing something. If you're doing something, do more. If you're already doing more, do better. So this is a journey at PM, hasn't been finished. There's a lot of work to do. There's a lot of things we can be proud of it, but that's not the focus. There's other things we need to work harder and improve significantly. And it probably that resonates with the pains that you might be feeling in our center. So I think, as I said, great opportunity to come together and try to solve these and join forces. So thanks so much again for the invitation, and happy to take any question.
Thank you very much, Ali. That was really wonderful and very eye-opening, as well as I thought a great vision going forward. Really enjoyed that. We'll open it up for questions, and I suppose we can put questions in the chat, or someone wants to raise their hand.